I hope everyone can hear me. And so let's begin the process of the meeting. And allow me from introducing, first of all, myself. My name is Mubashir Chaudhry. I'm involved with the public health. We have 53 people in this meeting so far. And with the past experience, I know for a fact that, some people have meetings already scheduled. I have in the meeting Steve Takacs, which is the CEO of South Texas Surgical Hospital. I have Brian Middleton joining us. He's a district attorney, Fort Bend County. He's a good friend. And Eric Lipper, he's head of Harsh and Westheimer Group. He's an attorney in Houston. And Melissa Sternfels. There are several members of the healthcare team. Pearl Warren, she's our vice president, and so on and so on. So I believe Dr. Umair Shah requires no introduction, but formally I'm obligated and I'm happy to introduce him as he well deserved. He well kept himself on the toes of himself, for fighting against COVID, educating people, and delivering the knowledge base nationwide on different channels and through different medias. He's an executive director of Harris County. He has a big role to play in Houston's health and developing the measures and guiding the public officials to take certain actions. So I welcome you, Dr. Umair Shah. Thank you so much for joining.
Thank you so much. Thank you for having me. Thank you for the leadership you've provided. And I really want to just thank everybody for joining this afternoon and look forward to a great discussion.
Moving forward, I have the second panel, very important member, Dr. Fayaz Bojani. Dr. Fayaz Bojani is also involved with public health from at least 20 plus years I've known him. And he's an MD, he's involved with the healthcare all his life, very hardworking soul. And he's the global head of Shell Corporation on the healthcare, arena. So I welcome Dr. Bojani to you for joining us in this panel discussion and taking an opportunity to guide the public. Thank you so much for joining.
You're welcome.
On the other hand, last but not the least, I have Dr. Faisal Masood. Dr. Faisal Masood requires no introduction also, but he's, first of all, I want to congratulate him for being appointed on the Mary A. and M. Samuel Deffen Senior Sentinel Chair in Anesthesia and Critical Care in Medical Center. Dr. Masood is an intensivist and critical care physician who heads Methodist Hospital of various geographic locations. He has a wide range of introduction, which is mostly given into the panel discussion that we have, flyer that we have circulated. If you can see that, if you can say a word before we
Thank
start.
you for including me in this esteemed panel. I think you will get the smart answer from my two colleagues. I'm the weakest link, but happy to join.
I admire your level of humbleness, sir. Thank you. So I would start with the first question that we were posted. We got these questions from all of you, and this is a very, very interactive and knowledgeable session going to be. The first question to you, Dr. Bojani, is that, are there still too many cases to catch? Or it's just a myth? Or it's just a flu?
Thank you, Mubashir. Well, as all of you know, there are several myths floating around regarding COVID. And I can assure you, and so will all of my co-panelists, that no, this is not just a flu. And I'll sort of help you with that. COVID is a serious and potentially fatal condition, and currently does not have a well-defined and standardized treatment and or any vaccine. As all of you know, that flu has both a standardized treatment and a vaccine which we take almost every year, or which is recommended every year. further to sort of highlight that this is a myth and it's way more important than flu, not that one is more important than other, flu kills, according to CDC, between 12 and 60,000 people in the United States. In just 6 months of this year, we have over 170,000 fatalities due to COVID. So I urge you to please take COVID very seriously. It is not a myth. Thank you.
Welcome. So I appreciate your response. I hope we can all benefit from it and stick to the guidelines that has been provided by the government officials under the direction of Dr. Umair Shah. But my next question is going to be from Dr. Faisal Masood. If you allow me, I'd like to ask you this question that was sent to us. How can we distinguish that we don't have a COVID-19 even when we have sniffles and body aches?
Thank you, Dr. Chaudhary. It's a very relevant topic of question, and I'm glad it's a very good question, especially with the flu season coming. Aches and pains are not uncommon. Sniffles and cough are not common. So there are certain defining differentiation what we have learned so far about COVID-19 and common cold and flu. So common cold really comes up gradually. That also COVID-19 is a little bit more gradual. Flu is a little bit more quicker onset. Some of the key thing is, you in common cold, you're going to have much more cough, dry coughs, and some sneezing. In COVID-19, one of the more defining feature is fever, which sometimes does happen, but is much more defining in COVID-19. One of the key other aspect is difficulty in breathing, which you really don't get to see in common cold. You can get to see in flu if it deteriorates. Aches and pains are there, but they're a little bit more pronounced in the COVID-19, especially with headache. In COVID-19, we're also seeing that people have much more what we call a gastrointestinal symptoms in terms of diarrhea that are related. So for a layperson, it can be sometimes confusing. Do I have this and do I have that? And especially if it's a concern. So what I would tell people is, if you're not sure, go to your primary care. They can do rapid testing with flu, and they can separate flu and common cold. And now with the testing for COVID also increasing, in a turnaround time, you can get it tested. So if you're not sure, go to your primary care doctor and they will help you answer the question.
Thank you so much. Truly appreciate your feedback. Dr. Umair Shah, I would like to get your attention towards this question, which is on everybody's mind. I think with the public health grip that you have and so much hard work that you put in and know all the latest and greatest, my question to you is that I received from the audience: what's going to happen in fall? Will COVID-19 spike up?
Thank you, Mubashir Bhai, for that question. And I also, I was remiss in saying to both Fayaz Wajani as well as Dr. Masood, the colleagues that are on this, I particularly want to really recognize their efforts. Dr. Masood and I have been through many wars lately. I only see him on CNN or MSNBC, so or Al Jazeera, something very far-reaching, and so it's fantastic to join this panel. And really, thank you for everybody again for being on this. We don't know what the fall looks like, unfortunately. I wish we had more information, but I will say a few things that's really critical to how we're thinking about this. One is that we have the confluence of where we are right now, which is obviously we've seen this incredible increase in our community here and across Texas. And now we're seeing some sort of leveling off and decrease in everything from positivity rate in the community, even the demand, unfortunately. That's one that's really concerning us for testing and hospitalizations and ICU admissions. There's a lot of this sort of decrease that's happening, and it's not enough that we're out of the woods, because we still need a significant driver for decrease. But at the same time, we have now concern about confluence of flu season, as Dr. Masood just mentioned. Confluence of flu season. We have election season coming up. We don't want to forget that one. That's going to be key as well. But on top of that is the real concern about resurgence of COVID-19 itself. What we are seeing in the Southern Hemisphere when it comes to flu, and we believe that much of this could be very related to people wearing the face coverings and doing all the things against COVID-19, that appears to also be having an impact on influenza flu, which is great news. But whether that's going to continue or not, or what level that COVID-19 is going to return with potential vengeance in the fall, is unknown to us. We do know this, that the COVID-19 vaccine that we have all been talking about, and obviously the federal administration has said that Operation Warp Speed would have a COVID-19 vaccine by the end of this calendar year. Now, Dr. Fauci at the National Institutes of Health is saying that it's Q2 at earliest of 2021. Dr. Peter Hotez here locally is saying it's Q3 of 2021. Dr. Masood and I have discussed this before, that we're really thinking it's somewhere somewhere in 2021, whether that's the summer or what have you, spring, summer, that kind of time frame. That means that we're really going to rely on public health preventive measures throughout this coming season until we are out of this, and we believe that a therapeutic that's widely available, or a vaccine that's widely available, will come to fruition.
Dr. Chaudhary, can I add one comment to that?
Yes,
sure,
sir.
Please.
So the take-home message, which I think Dr. Bajani, Dr. Shah, and I will say, is get your regular flu vaccine. If you didn't get it the last time, get it. You can't not get it. And, it's, there's no, September, probably mid or something. Yeah, I would encourage everybody in the audience and everyone, get your flu vaccine. That's the only thing I like to add.
Wonderful. Thank you so much. That's a very good addition into the response. Before I take from our set of 18 questions, maybe we could cover all of them, but I want to also give audience an opportunity to ask a question. I will be requesting Dr. Gohar Wali. She has been a internist and the family practice physician for all her life, and we used to work in the very beginning of my time in Houston. So she has a question, and I would request you to unmute yourself and please then ask a question. Yes, there you go. You're good.
Can you hear me, Moshe?
Yes, thank you.
Flu season is coming, and when a patient comes to our office, should we do both the flu test, quick flu test, and the test for the COVID also? Not to miss COVID now?
I think I will add, and I'll defer to Dr. Shah and everything, is that I think the rapid flu test is one of the most important things you can do, because you and I both know that that is a lot more common than anything else. And if there is an uncertainty, and actually more availability of rapid testing with COVID, I think based on the symptom, you can add it. But one should always do the flu test regardless of all of these things, because that is more than likely to get missed.
Yeah, I was just going to add this very same thing. Dr. Masood is absolutely right. We want to emphasize that influenza will not have gone away. It's going to still be there. And so that is the primary that we want to make sure that we let people know about. If we had rapid COVID testing of the ubiquity, the availability across the system, like you have rapid flu, I would say do both, right? But the challenge is we don't have that, and that the testing constraints remain. The other piece of it, which is clear, is that you have to make the clinical judgment, as Dr. Masood and Dr. Bajani originally talked about the real trying to decipher and delineate who is somebody who's more likely to have influenza versus COVID. It is very difficult to do in a clinical practice setting. It's very difficult to do in a population health setting. But I do think it's important to try to make that distinction and utilize your limited resources on COVID-19 testing, though I think both are in the mix for patients if they have symptoms that are potentially either.
Wonderful, wonderful.
Thank you.
I hope that answers, Dr. Wali, your question. And,
Yes.
you know, I have another great gentleman who's the CEO of South Texas Surgical Hospital in Corpus Christi. He has joined us. His name is Steve Takacs. Steve, while you are getting ready for your question, I want to ask a different question from Dr. Shah, also Dr. Faisal Masood, and Dr. Bajani. If any one of them or all of them can contribute into this. The question is, what is the truth in the news that children carry coronavirus in their nostrils, and how dangerous it is for the children?
Well, you know, I'll start by saying that, you know, there seems to be a distinguishment between the young children, essentially 9 and under, versus the children that are, you know, 10 and above. What we're seeing is that the children that are 10 and above very much seem to be able to have enough virus in the nasopharynx that they essentially can be treated as adults or considered as adults. There's some uncertainty on the younger population under the 10, 0 to 9, if you will. But there is this really that CDC is reporting that we are seeing children who have viral loads in the nose, even if they are younger. And so I don't think we can let off the guard. I think this is one of the reasons that Harris County has been very clear, our health department. And, you know, we did get quite a bit of, you know, great positive feedback from teachers and administrators and parents. But we also did get, as you know, even this week, 10 independent school district superintendents sent a letter to me about the concern with our recommendations and guidance for school reopening and when that would be safe for in-person activities. And we have maintained that it is very, very important that with transmission rates as they are in our community right now, that safe reopening is one thing, but maintaining safe reopening is an additional thing. So I do think kids can carry the virus. We have to keep that in mind. But I also think that some of our data for children has been skewed by the fact that many children across the country have been essentially at home since March because of school closures.
Thank you so much, Dr.
The only thing I'll add, Dr. Chaudhary, is that we're still learning. And what I can tell you is that some of the postulation is that the less number of younger kids, especially less than 10, as to why they have not fallen sick in the acute phase of COVID-19 is that this disease pattern, a lot of the sickness is related to the body's response or immune response to the virus itself. And the speculation is that the immune response is still maturing. It is not as robust as adults. So perhaps that may be a contributing factor for younger children to not get that sick. So I just wanted to add that comment to Dr. Shah's response.
Thank you. Thank you.
Yeah, Mubashir, just to add, I think, or expand what Dr. Masood and Dr. Shah said, because of exactly that reason, most of the young children or many of the young children either have mild symptoms or are asymptomatic. And if they have mild symptoms or asymptomatic, the likelihood of their transmission, because nobody knows, their parents don't know, etc., is higher. So just to complete that.
No, absolutely. This is a great addition that you
regarding this thing. I wanted to know, like, there is somebody asked this question as well, like, what is this multi-system inflammatory syndrome? in children, which is called as MIS-C. And is it only children only are at risk, or some underlying condition patients are also?
Okay, I'm happy to take that question on. So you bring up a very important question. That is a worry of a lot of parents because with the whole focus on COVID initially was elderly, then the focus has shifted to a younger adult, less than 50, and now what's going on with the kids, and that's one of the fear factor. So what is this multi-system inflammatory syndrome in children, or MIS-C, is wherever it was initially reported from England. There were about 10 cases in which they found out that children who developed symptoms with other disease process similar in which the inflammation or response led to affecting your heart, skin, and lungs, and they became very sick. And when they traced back, it was that they either had COVID testing, they were positive, or their family member and their exposure to that. So that was initially reported a few months ago. And so CDC started to track of it. And as I recall, CDC has about 500 cases, all over the country so far, 500 plus in which they have reported. And interestingly, that this manifestation of this disease is not an immediate, it is much more delayed. It is up to delayed 4 to 6 weeks after the child has either been in an environment in which others have been positive, or they themselves are positive when they were tested. The good thing is that it is still extremely rare for children compared to the number of children who have been positive and exposed. But it is worrisome. It is a rare thing. What I can tell you is that it's still a huge inflammatory response, but a much more delayed response. So I think that so far we have learned so far from the areas Mayo Clinic and other people have reported and CDC reported. So more to come on it. But the good thing is that the medication is, especially IVIG, which is an immunoglobulin, the kids have responded very nicely to it. And there's a very low mortality or death rate related to it. So that's a long answer but it is important for people to know.
Oh, this is very, very much appreciated, Dr. Masood. The insight is very important. People need to know what they can't find the information from different channels or different areas. Steve is another good friend, and he's the head and the CEO of South Texas Surgical Hospital in Corpus Christi. Steve, first of all, what is your question, and what are you facing as head of a very, very busy hospital in Corpus Christi?
Are mostly a surgical hospital, so I can give you a little bit of background. We do not have the facility to care for COVID patients. Keeping that in mind, we've got 11 ORs, and we're one of the, I guess, if you will, as COVID-free as we can be, facility within Corpus Christi. We're actually a 5-star CMS-rated, quality-rated facility here in Corpus. And so we have one floor, we have one single AC unit, we don't have ventilators, we don't have an ICU. So that creates some challenges for us to care for COVID-19 patients. With that said, we do treat them in the ER. We have a lot of them show up at the ER, we stabilize them, and or send them for testing, and then send them home to quarantine. If they need to be transferred, we send them to other hospitals. So with that said, we also screen and do everything possible to try to ensure that our doctors, our surgeons are safe and that they are not COVID carriers, and also that our patients are kept extremely safe. We don't allow visitors at this time. At one point, we did open up to visitors, and we found that to be a challenge, assuring that everyone was safe within the facilities. So we are continuing to run cases. We're are still running, 40, 50 cases a day. So with that said, I guess the one question I had was for the panel, and I don't know if I'd like to bring this to Dr. Shah or maybe Dr. Chaudhry, maybe you can guide me to the next, I guess, appropriate individual who can answer the question.
So, Dr. Shah, would you like to answer?
Yeah, I had some trouble hearing the question. If you could.
I haven't given a question yet. I was
okay.
given more of a roundabout summary about our facility. So the question would be, Dr. Shah, if you can hear me, the question would be, do you feel that COVID-19 has mutated? And how do you feel that will impact us in 2021 with the onset of a potential vaccine? Will the vaccine be even efficient as we enter 2021 if it is mutated, obviously? So that's my question. Did you hear that?
I did. Thank you. And first of all, thank you for everything you all are doing in South Texas. It has been incredibly challenging in your communities, and our heart goes out to all of you for everything that's going on in the Valley and on the Texas-Mexico border. So I really just want to just extend our support. A lot of health colleagues at the health departments in Hidalgo County and Nueces County, et cetera, that are really working hard, and I know you all are in healthcare as well. So just want to give you all that shout out from our standpoint, everybody here locally. That's a really great question. There are we know that actually the virus that was circulating in China is different than the virus, somewhat different than the virus that's circulating across the globe, including in Europe. There was a different strain, and even including here in the US. And in fact, there was a study that came out from Baylor College of Medicine, I think it was about 6 weeks ago, that there was a different strain that was in Texas that really allowed it to spread. The thought was it could spread more readily. So we do know that this concept of whether it's a genetic, what we call either a drift or a shift, depending on how major it is definitely in play. And it's not surprising that occurs from time to time with a number of viruses, including and especially when you have novel viruses. What I would say is that when it comes to the vaccine, those are the considerations that are being put in place right now, and why this is a very difficult process of not just the phase 1, 2, 3 trials, and not just that it's a small group of people to really engage in to understand safety and efficacy of those vaccines, especially for a larger population, mass vaccination, if you will, to the population. But they are taking that into consideration. Now, if there is a significant shift in the virus itself, then that can have an impact on the effectiveness of a vaccine. We're hopeful that does not happen. We know that there are, obviously a different virus, a different infection, influenza, flu. We do know that are efficacy and matches and mismatches and undermatches every year, depending on what's happening in the Southern Hemisphere, how much there may be a change by the time the vaccine, the virus gets to the Northern Hemisphere, and we have the flu vaccine that comes out. So we do our best to predict. I don't know if Dr. Masoud or Dr. Bajani have any additional. I will be honest that our team has been working very diligently on vaccine preparation for COVID-19, but it's been really hard to get that information from our federal partners, largely because I think it's still being developed. And number two is that there's a lot of uncertainty to the timing of that vaccine availability. Dr. Masoud or Dr. Bajani, anything you want to add?
I'll defer to Dr. Bajani first.
Yeah, Umair, thank you for that. Fully agree with everything Dr. Shah said. I'll just give you a sort of a context around the mutation. Many viruses mutate over a course of time. Some become more deadly and some less. Yeah. If you think about it, humans are a host for the virus. So it is in the interest of the virus to infect more people and not to kill a lot of people, because with the person being dead, the virus is gone, right? So no more host, no more food, no more shelter. So so that's why it is suggested now, and perhaps in some instances verified, that what Dr. Shah said, that the virus circulating here with some minor mutation is perhaps more highly infective and has slightly lower mortality. And you can see that in the data that we are now seeing in terms of the incidence of condition, as well as the hospitalizations, which have decreased, and the mortality, which is starting to decrease. Dr. Masood, anything to add, please?
Yeah, I think we actually talked about it yesterday. So it is, I think, the fourth or fifth version of mutation, and every virus mutates, as was already mentioned. So it's not uncommon, it's not scary. And the preliminary data that we have seen, that it is a little bit more, as far as in terms of dangerous, slightly dangerous is the wrong word, I mean, maybe causing more harm. But the rate of infection, that means the ability for it to spread out, is slightly less. Clearly, Dr. Shah brings about a very good point. When one looks at vaccine development and vaccine, that's why it takes time, because you have to think that 1 billion doses have to be, for example, given. If you have a margin of error of 1 or 2% of having problems or anything, then you're missing a lot. And FDA has a very stringent criteria for some of these vaccines. So that's why it takes a little bit of time for all of these vaccines to develop. So that's my addition.
Thank you so much. I do have another, one of our audience, want to ask a question. Her name is Pearl Warren. She's our vice president as well. She has a background of RN. She has served in healthcare all her life. Pearl, you want to go ahead with your question?
Yes, what I wanted to ask about, since I had heard about it recently, is the effects post-COVID, or even if someone had a negative COVID test, the people that are having a lot of cardiac or rheumatoid type symptoms and are being called the long haulers, people with extended symptoms, what are we seeing or commonly in people with those type of symptoms?
All right. I'm happy to answer that, because actually we have done some work on it and we are doing these things. So far that all the data and our observation and nationally is that a lot depends on how sick you get. If you have COVID positive, but you don't get admitted to the hospital, more often than not, even if you may have longer aches and pains and headaches, you don't seem to have longer duration of symptoms. And longer is a relative terms. You're talking really about a few months for right now. If you are admitted to the hospital and you require oxygen, or you require a lot of medication, or you're required to be sick enough to have being admitted to the intensive care unit, those patients have found that we are learning that they have a much more impact and damage to their lungs, which is similar to other diseases which are long-standing. That means the potential of lung damage can be a lot more longer, because that damage is similar to other long-lasting disease. What we've also learned is patients up to 50% can have a heart function which at least is temporarily compromised, and kidneys. One of the other thing is brain, and and especially if you get admitted to ICU, that these patients still have memory challenges and have some long-term weakness. And again, I'm talking about 6 months data. I'm not talking about years data. So depending on the severity of the disease, depending on if you're getting admitted to the hospital, your long-term impact are now being studied. We in fact have an app also, which we in Methodist, we are working with patients that get that, and we're tracking them, because we feel this disease is going to be a long-term chronic healthcare problem. Thank you.
Thank you so much, Dr. Faisal Masood, for while I'm still entering people into our meeting as they continue to join. So we have, at this point, 72 people listening and benefiting from this beautiful conversations. So I have a question that I would be asking Dr. Fayaz Bhojani. Dr. Bhojani, you were in touch with me when you were traveling to London, exactly when it started. And we had this conversation. I had to cancel my trip to Pakistan. And from that standpoint, and from your learning experience, this question is relevant. Why contact tracing is important?
Okay. Well, I think most of you know what is contact tracing, right? Also known as case investigation and contact tracing. They are fundamental activities that involve working with a patient who is diagnosed, whether it's symptomatic or asymptomatic, with an infectious disease. So in this case, COVID, to identify and provide support to people who are then called contacts. Contact of a person who has been diagnosed with COVID, and to see whether they have been infected through exposure to this patient. Now, this process prevents transmission of disease by separating people who have or may have an infection or COVID infection from the people who do not. The importance here, when most of you or we hear about there is not enough testing available, the purpose is if you test the people quickly, you will find out whether they have the disease or not, and you can quickly then separate the contacts as appropriate. So for example, if you have the testing results back in one day, you can jump on it right away and stop the spread of the condition. However, if you get the result in a week, it's already too late, because every person is infecting at least 2 people, and then the 2 people infect 2 each, and then by the time you go further, it's a long chain. So it is a core, as Dr. Shah would say, disease control measure that is employed by public health professionals over the course of decades. And therefore, the case investigation and contact tracing in the public health arena are considered the most effective part when a multifaceted response to an outbreak. Thank you.
Yeah, if I could, Dr. Bhojani is absolutely right, and I would be hard pressed to not say something on this, because this is what we've been doing for actually months. In 2 days, it'll be 3 months. May 22nd, we hired our 300 contact tracers at Harris County. The city of Houston, I believe, just has brought on their 300. So we have 600 throughout the 2 health departments in our community here. Fort Bend County has as well. Dr. Bhojani is right. This is a tried and true method of fighting different infections across the system, whether it's tuberculosis or whether it's dysentery or any other kind of diseases. We've used this domestically. We've used this globally. Somehow, all of a sudden, there's 2 things I want to say. One, somehow, all of a sudden, this has become this incredible term for, it's like a sexy, the buzzword of the day, contact tracing. And then the second is that everybody's an expert in contact tracing. You don't know how, when we made a public announcement, Judge Hidalgo and myself, about contact tracing, all of a sudden we were flooded with all sorts of private sector, and I am an expert in contact tracing, and let me tell you how to do it. And some people that, you've never even heard of them doing contact tracing, they were experts in contact tracing. Dr. Bhojani is absolutely right. This is not just about CT, contact tracing. It is about an entire system. And I think it's important to remember that one is that we start with communication and engagement and getting outreach out to the community, because it's about somebody has symptoms. You want to get them tested as quickly as possible. There should be no delay. And unfortunately, we've seen delays in people going to get tested. So testing then becomes the foundation of this. My CNN moment was when I said, it was my Johnny Cochran, O.J. Simpson trial moment, when I said, you can't trace without a case. So that was my big moment. You can't trace without a case. If the glove don't fit, you must acquit. That was my, if you can't trace without a case. And so testing is the foundation, but then testing had delays, as Dr. Bajani said, in getting the results back. So we were in, especially at the federal sites, it was taking 2+ weeks to get the results back to the individual or the health department. So that is essentially useless to do any sort of case investigation, contact tracing. Not impossible, but less effective. Then you get, once you get an individual who is now tested positive, then our epidemiologists do the case investigation. They call that individual, they make contact, they determine what they've been doing, who they've been around. Obviously, none of us remember who we've been around 2 weeks ago, but if you get that result back in just a couple of days, you then are more likely to remember who you've been around. That case investigation starts the sort of illumination of contacts. That gives you contact tracing. You can't trace without a case, without an actual case investigation, without a test that comes back positive. That's why testing is a foundation. Then contact tracing then determines what I call the ABCs. You raise awareness to the individual of they've been potentially exposed to somebody who has been tested positive. And BC, you behavior change, isolate, quarantine, interrupt transmission, and get tested, which starts that cycle all over again. That's why contact tracing is a part of a systematic cycle. And Dr. Bajani is absolutely right. Dr. Masood has done so much with Methodist, really trying to determine how hospitals and healthcare systems can help us get the jump start on this. But I tell you, it is a field that unfortunately everybody has tried to become experts in, and you know, it's unfortunate, but that's where we are. So I just wanted to add that passion to Dr. Bajani's answer.
Okay. I think, you know, Mubashir, with your question, you got Umar excited.
Yeah, it comes right through.
I need to get out more. I need to get out more, right?
I think I'd like to add one more thing. I want to acknowledge one of my colleagues who's here, Dr. Zeenat Safdar. She is on this thing. She's a great partner with us, and she's done a lot of education for local and international communities. So I want to put a shout out to Dr. Zeenat Safdar. She's a great partner with us. So
thank you very much, Faisal. You have done a great job in bringing Methodist to the forefront of COVID fight. I don't know if I'm muted or not.
No, you're fine.
I can hear you.
I'm fine. Okay. So thank you very much. And Umair also. Umair, you have done a great job also bringing us, us as a diaspora in front of the community, and also the great work that all of you are doing.
Thank you. Likewise.
Thank you.
So going back to, first of all, Dr. Shah, this was amazing. This is what our people want to hear. Your commitment and your excitement level shows how much you are, feeling the pain for the community out there. Dr. Faisal Masood, on contact tracing, I just want to get your take as well on that. That if you have any comment to add.
I call Umar. That's
Got
it. I'm not an expert. I will call the expert. I'm not an expert.
Got it. But let me ask you the next question.
I call Dr. Masood on everything ICU related and anything healthcare related. So we got mutual admiration going here.
So here's a question for both of you, that if you had a virus, can you get it again? And if so, will it affect your the same way?
So, what we've learned so far is that if you had viral COVID positive, the new or especially the new CDC guidelines, and they're really based on literature and studies and data, that you have immunity up to at least at minimum 90 days. Now, there is some recent study that we saw last week in which they're speculating that perhaps the immunity can be much more longer. Now, you are positive, but now we're learning also that if your symptoms recover, then 10 days after a positive result, you don't have to repeat that test if your symptoms are resolved. You may choose to repeat that test, but you don't have to prove, because you may still turn positive, but you are not infective. That's a very, very fine point, because you may turn positive because the virus is the elements of the virus are present, but you're not a source of infection. That's very important for people to know, because what we don't want is that if you're positive, that you're getting tested every 3rd, 4th, 5th day. If your symptoms have resolved, That means you're not, for example, if you have fever, you don't need for up to 72 hours, then, more likely you resolve. You don't have to kind of prove it again. So this is again evolved compared to where we were in March and April. In March and April, the guidance are different. So as you can see, we are all still learning. And I think this is the best I can tell you at this stage. Umair?
Yeah, I think Dr. Masood, you said it absolutely right. The CDC did move from a testing-based strategy for example, return to work, to a symptom-based strategy, onset of symptoms, termination of or ceasing of those symptoms, where you don't have to retest. And so Dr. Masood is absolutely right. Now, I do want to clear up a couple of myths that are out there. There is a myth out there that, one, if I get tested, people start to think that somehow testing is immunity. So it's almost like a badge of honor. I got tested, and so I'm immune to COVID-19 now because it was negative. That's a myth, obviously. The other myth is that if you have been tested once and it was negative, that a month or two later, if you've been exposed, for example, or you have symptoms, that your test from 2 months ago is also protective in some sense for this new thing. So I was in some outreach events, and I'll tell you, it was especially in our Hispanic community. I asked some of the elder people that were there. I said, "Well, have you been tested?" And they were like, "Yes," and they were all excited. They thought that they were ready and they were safe from COVID-19. But when I asked them when, it was really 2.5, 3 months ago. That doesn't necessarily mean anything if they've been exposed or they have symptoms today. So we have to clear up some of the misinformation. And Dr. Masood and Dr. Bajani and Dr. Chaudhry, thank you for doing this. I would say that one of the biggest things that we've been finding is that as we evolve in the pandemic, the misinformation, it takes a while for that to then get resolved. And you're still trying to catch up months or weeks later with misinformation that's in the community. And that includes our South Asian community. We really want to make sure that our South Asian community in particular also thinks about how it should protect itself, our community members. We are not immune to this virus because of our color of our skin, our religion, our ethnicity, our national origin, or anything. We are all susceptible to this virus. It's all about our exposure and what we do to limit that exposure or the protective measures. If we don't take those, then we too can be subject, unfortunately, to this horrific disease.
So I'll add 2 things to Dr. Shah thing. If you get tested negative today, the only thing it tells you are okay today. There's no guarantee for tomorrow. How also, if you get exposed to somebody who's infected today and you go and you get yourself tested same day today, you're going to be more likely negative today because the virus takes time it takes about 2, 3, 4 days and all the stuff to really be positive. So I think I just want to be added to what Dr. Shah is mentioning. Once you get tested today, this only means you're safe till today. That's it. And if you get exposed today, if you go same day today, you will be negative again. So you have to wait for it to be positive. That's it.
And I just want to add one more thing to that is that a patient who gets COVID, as Dr. Faisal said, it doesn't mean that they cannot get it again. They can definitely get it again. We have seen it in few of our patients that the immunity in some patients, it wanes off very fast. Some people don't even mount an antibody response. So if you check the antibodies would be almost 0, which is strikingly common. And in some patients, they will have a strong antibody response. So it really depends on how much immune response you mount for the virus to gain the immunity. So this is a false, fallacy that I got COVID, so I'm immune to it. I will not get it again. They will definitely be able to get it again if they get exposed again. So it's just something that we need to do. I just heard a story of one of my friends. They had a little small wedding in a small town of Mississippi, and he didn't go, but other people went, and all of them who went to that wedding tested positive, including the bridegroom and the bride. So just a warning.
Yeah, thank you so much, Dr. Safdar. I have another one of our audience. He's a very, very important team member, Richard Valentine. He has a question. Richard, could you please go ahead, see if you can unmute yourself, and that's fine. Yes, go ahead.
Yes, we've been talking about testing, and the news outlets, particularly yesterday I was listening to NPR, and they're saying that admissions to hospitals have slowed, which is good, but they're saying that more cases are continuing to be identified, and that in conjunction with this, testing has actually slowed. Is the testing slowing because people have a false sense of security, or what do you think is the reason for that?
Yeah, I'll take that one. That's a. Let me answer it with the summary. We don't know. That's the summary answer. Okay. Let me start with that, but let me go back now. It is true that, for example, in the county and the city, our sites across this region, we're seeing less demand. So right now, if you went to 832-927-7575 or readyharris.org and you try to get in to plug in for testing, you can get testing very readily. If you showed up at a testing site, you would not have much of a wait. In fact, you'd have no wait. You'd be out in about 10 minutes. There are no lines. The turnaround of the testing is now 2 to 3 days. So think about all of those. That's a very quick process. However, we're not getting people to get tested. And that's a phenomenon in Texas. That's a phenomenon across the country right now. I don't believe anybody knows. Locally, we think that there may be some relaxing because we're seeing people thinking that because the hospitals are seeing a decrease in the media stories around the healthcare system improving, that people are saying, well, I don't need to get tested. We've already talked about the false sense of immunity, the false sense of I've been tested once, I don't need to get tested again. We're also recognizing that in certain communities, for example, our Hispanic community, very concerned about this issue, that there may be, again, concerns about going to government testing sites. Maybe there are concerns around, immigration or citizenship, things of that nature. There are others who we unfortunately feel that there are linguistic and cultural barriers that still are in place. But the answer, again, back to my summary answer, is we just don't know. And what we are doing is to remove every barrier that we can think of. And our team is working day and night on this. We, for example, have expanded out to evening hours a couple of nights a week. We're testing on, we've already been testing on the weekends, but we're doing mobile testing. We're getting into, churches, mosques, synagogues, temples. We're going to businesses. We're doing at-home testing. Every single strategy we can think of, but we just don't know why the testing demand has decreased.
Thank you so much, Dr. Shah. That was very, very helpful. Lines, I wanted to ask you and Dr. Zina Safdar or Dr. Faisal Masood in particular, that what about the latest treatment? I have heard some things, but I don't want to, vouch for that unless it is coming from the experts. And has there been any cases of reinfection?
Let me defer the treatment. I have my answer. I'll just say globally, as part of our school reopening and other metrics, we did put in the red, orange, yellow, green, that a widespread, widely available therapeutic or vaccine is critical to getting to green. So I've got thoughts about that, but let me defer to Dr. Masood, Dr. Safdar, and Dr. Bajani, because they may have some additional thoughts.
So for treatment, clearly in the last 4 or 5 months we have tremendously evolved. And I can tell you that you all should be proud of the Texas Medical Center, all hospitals, all doctors, that they've done an unbelievable job of getting patients through. Our mortality rate or the death rate is so much more lower compared to most of the other major cities in US and outside US also. We have learned a lot in terms of how to best manage patients without putting them on ventilators. We have learned a lot how best to use plasma therapy much more earlier on. Clearly, our institution was one of the earliest to use plasma and remdesivir. We have many trials happening, a lot of therapies, and including dexamethasone or steroids, and putting people on tummies, how best to manage the fluid, how to follow up with that. So what I can tell you is that the treatment evolution has been tremendous. Our approach is a lot more different and improved compared to our March and April. But we are still learning. There's so much more to be learned from this thing wise. But the teams in the Texas Medical Center and most hospitals are kind of what I would like to call as better tested. We're better prepared. We better do that. So I think from a team perspective, a lot of stuff has improved. We have still a lot of trials happening. But I want to be cautious of news media generated healthcare disclosure versus actual science-based disclosure. So that's my 2 cents. I'm open to Dr. Sadda to add.
That's exactly right. We have a treatment algorithm which is evolving. So you may see one thing and tomorrow there may be another medication that is being tested or is being approved. I think Methodist has done a great job in getting all the new studies on board. So we have novel therapies that are, I think we can talk about those later, that we are testing right now in COVID patients. There's another study looking at prone positioning, which is laying the patient on their belly to recruit the lung, which is not being used. There is the oxygen delivery. There is the inhaled nitric oxide. There's another one looking at vasoactive intestinal peptide. So there are novel therapies that are being tested. Some of them actually have shown very positive outcomes, such as Evaptidil. So there's just a short synopsis of what's happening right now. We have, I think, more than 20 trials. Thank you.
Welcome. So keeping the time in view, we're exactly at 4 o'clock, but since we are supposed to be ending this very, very shortly, I may have like a couple of more questions with all of your permission. Dr. Faisal Masood, can I ask those?
Sure, absolutely.
Okay. So one of the question is the best test for cases that only present with the GI symptoms.
So, there are, you can actually do PCR testing for the stool. And, there are patients who present with GI symptoms like diarrhea, unexplained, and that's one of the more common symptoms. So in those patients, you can do PCR testing, which is a way to test for this viral, nucleic acid. But in those patients, some of those patients, we also do nasal or other testing also. So there are testing available. You can do the testing. There's no one better versus the other because patients who had some of those patients who had gastrointestinal symptoms were not producing diarrhea, and some of them didn't necessarily have stool positive, but they had nasal positive. So the virus sometimes has a global impact where it causes diarrhea, and that can be a symptom. Or in some cases, the virus directly attacks the cells lining the intestine, especially the small intestine with the receptors, and the presenting or the first symptom is diarrhea, in which the virus is being shed a lot more. So I would recommend that, if you're going to testing, I would recommend getting both the stool testing and swab testing if you specifically have GI gastrointestinal symptoms.
Okay.
And the only thing I would add, Dr. Chaudhary, on that is Dr. Masood is absolutely right in everything he said. What I would add is that our colleagues at Houston Health have been working with both Rice University and Baylor College of Medicine on a stool sampling study, which is more of a wastewater PCR testing. They're testing the wastewater, and there are some studies that show that if you test the wastewater, you can actually have indicators of how much transmission is occurring in certain parts of the community or the entire community just by the waste that's going into the wastewater that can be tested. So more to come on that, but just wanted to share that as well.
Thank you so much. Thank you. One question that is I'm saving the best for the last, but before that, I want to ask a question where I want to give an opportunity to Dr. Bhojani as well, that if he likes to contribute into this, that once we have this vaccine, how long will it take to eliminate COVID-19 epidemic in our region? Dr. Shah, you can go for it.
Okay, I'm sorry. That was for Dr. Bhojani. It's really dependent on how long it takes. First of all, it's depending on how effective and efficacious that vaccine is, but it's also dependent on how long it takes to get the vaccine out to a large group of people in the community. We just don't know. I mean, right now, obviously the vaccine's being worked on. It's being there's outside of the pronouncement by the Russian government. We know in India, Glaxo is working on a vaccine. There's Dr. Hotez with Baylor College of Medicine is working with PATH in Seattle. That's also working in India and with partners there. We obviously know in Europe there's vaccine trials happening, and obviously here in the United States, including locally here in Texas. And so it's a two-shot vaccine. We don't know all the details of it because it's still in development. It's still in trials. I do know that I have colleagues at the national level who themselves have joined in, that they are being the initial participants in the trials. So there are a lot of moving pieces related to this. But the truth is, it really depends on how effective it is and how widely available it is.
Thank you so much. And the last question of this session, keeping in view of the time and being very respectful to everyone, what would the leaders in the fight of COVID-19 ask of our local, state, and federal government to help slow the spread, get COVID under control? That's more likely of Dr. Shah's question. So we want to put you on the stand.
Well, I think that's, it's about resources. It's about having a strategy. Let me say two ways of answering that. One is that I would hold all of us accountable, both on the government side, but also on the community side. I think all of us have a role to play. We have a very important election coming up in November, and there is a 4-letter word that I think is absolutely critical. It starts with a V, it ends with an E. Vote. I'm not going to tell you who to vote for, but I say please vote. You have to be part of the civic engagement process. We are not just global citizens, but we are citizens of this country, and we really need to make sure that our voice is heard. So that's the first thing. The second thing is that anytime you have inconsistent messaging, and I don't care, I'm in local government, I'll tell you, I don't care if it's at the federal, state, or local level. If you have inconsistency in messaging, policies, anything, then the individual community member, it causes both confusion and complacency. So if you see someone at the federal, state, or local level saying masks don't work, or I'm not sure I'm going to wear one, that individual at the community member then says, I'm not going to do it myself. And because many of us are healthcare folks or public health folks, we can make decisions in a way that's health educated or health literate, but not everybody can in our communities. And what that does is it drives people to chance their health. And when you chance your health, unfortunately, what that does is that people get in trouble. And so I would say vote, and also we need to eliminate this inconsistency in messaging and policies at the federal, state, and local levels.
Thank you very much. Dr. Faisal Masood, before I ask you to conclude this session, I would like to address to all ladies and gentlemen who participated. At all time, there were 73 plus people present in this learning session. Ladies and gentlemen, these are the 4 pillars of healthcare that I was able to present to you. Our organization is very thankful to you for participating. And also, I'm very grateful to all these 4 pillars Dr. Faisal Masood, Dr. Umair Shah, Dr. Zina Safdar, Dr. Fiaz Bojani. These lady and gentlemen had submitted their lifetime work and dedicated their time towards community welfare. So I'd like to thank you, all of them individually. Dr. Faisal Masood, you have the conclusion.
So thank you, Dr. Chaudhary. And I think, first of all, thank you to Dr. Chaudhary and his organization for us to have this forum. I think we are very blessed to be in Houston. I think we are blessed to be in Texas, that we have people who want to do good and to do better. Our community holds the power to change the trajectory of all of this thing. Our communities, not me, not Dr. Shah, not Dr. Safdar, our community. So we want to help you all. We can help you all by you all helping us. So I think, that's, I don't have any affiliations, we don't look at any of this and that. So what we have seen repeatedly is mask wearing makes a difference. There is so much. Even Goldman Sachs published a paper that is the GDP gets impacted. So if Goldman Sachs are selling that, they probably have better number-wise. So I believe, be safe, wear your mask. COVID will all get through together. So that's my own thing. And thank you all.
Thank you very much again, everyone. And I would like, with everybody's permission, end this session for everyone. I see a last person entering, but we have concluded the session successfully. Thank you so much.
Thank you.
Thank you, Dr. Chaudhary. Thank you all.
Thank you, everyone.
Thank you so much.
Thank you.